Last year, I introduced the concept of integrative oncology nutrition. And this year, my goal is to show you what it looks like when it's applied. How many of you in here heard the lecture last year? Not so many. So I put more slides in here than I intended to cover, and it's because I wanted you all to use the email at the end of the presentation to request the slides so that you have some to refer to. Because when you go back and read the slides after the presentation, they'll make more sense. But I'm going to glaze over a few of them because we're starting late and because I have a lot to say. And I want to show you the more applicable parts than just the concepts. So what I'm going to do, like I said, is just kind of glaze through the introduction, the review of what it is for those of you who were here, and talk about two common challenges that we see in oncology practices today and cancer patients complain of. Talk about the mechanisms that drive them and the treatment targets and how those two overlap with those two conditions, and therefore how treatments can overlap, and give you some practical tips into how to start addressing these things. So for those of you who aren't familiar with it, integrative oncology is not complementary and it's not alternative. It's taking the best of both worlds, taking the best of natural medicines and the best of oncology and marrying them. So the best approach comes with a multidisciplinary team. It's also very patient-centered. So I'm giving you some general information here, but everything we do when we're approaching care from an integrative standpoint is very highly personalized. It's precision medicine. And then we're looking at cancer as a metabolic disease. And that's important because it's not just doom and gloom. It gives us a lot more hope in treating patients. And there's this misconception that natural medicines aren't evidence-based and they're not effective, but that's just highly inaccurate, and it doesn't reflect what's in the literature or the experience many integrative practitioners have had. So when we're talking about nutrition, integrative nutrition, whether it's in oncology or not, what we're trying to do is optimize physiological function, bring the body back to a functional status. And it's through that that we can improve patient outcomes, and you'll see that applied. And when we look at these mechanisms that are driving disorders, we can identify different foods and food components that are going to be more beneficial to patients. So that's where some of this personalization can come in. Our patients are going to have therapeutic needs. Basic diet, like a very pristine, homegrown, clean, organic diet, can meet basic needs. But these patients' needs are so far beyond basic needs that we're going to have to bring in something to bridge those gaps. And that's where supplementation comes in. Most integrative practitioners are recommending some sort of supplements, but doing so with evidence. And that's a very strong point in integrative medicine, is that it's very highly evidence-based. I have tons of references. Any of you who want them, I'm happy to provide a list. The last lecture, when I stopped counting, there was 42, and I didn't count this one. So we have an emphasis on what's in the food, not the calories in the food, not the carbs in the food, the protein in the food, but looking at what compounds are in the food that can moderate gene expression, glucose modulation, etc., inflammation. And we're also treating the whole body. There's the physical self and the non-physical self. And when you have a non-physical self that's not so healthy, I think everybody in here can recognize it takes a toll on the physical self. So you can't neglect both parts of you or the multiple parts of you. And we also need to stop treating in isolation and treat the whole being. And when we look at things from a metabolic standpoint, you have to do it that way. So what we're doing as integrative nutritionists in the oncology setting is really looking to drive patient outcomes for the better. And that means improving quality of life by decreasing symptom experience during treatment. We know that 2/3 of cancer patients are going to have latent effects of treatment for 5 years plus. So we really want to work as much as possible on helping patients tolerate their treatments better. And for some, that can mean the treatments are more effective. They don't need as high a dose. And for some, it can mean they can take higher doses. Many of our standards of care in oncology have a nutritional hit. They drive down some of the nutrient stores. So as integrative nutritionists, we're always looking at what are the depletions coming and what foods can we use to bridge those gaps and supplements when needed. So with dietitians, most people in this room probably who have experience with nutritionists have experience with dietitians. It's a very different approach, but most integrative nutritionists are going to be dietitians. The way I explain the difference between the two is dietetics is like my bedroom closet and nutrition is the rest of the block. I'm not going to lock myself in the bedroom closet and never talk to anybody. I'm going to walk around and talk to everyone because that's when I'm going to have the most impact. So as integrative nutritionists, we can do what dietitians do, which is great for short-term, temporary symptom management, like how to eat when you can't chew, what to do when you can't swallow well. But we're looking at what's driving some of the problems in cancer. Where did the dysfunction happen? Where was the breakdown in the process? Let's target that. So we get more long-term symptom resolution and more long-term enhancements in quality of life. So this model is the Hanahan model. This is the updated version in 2022, and this speaks to cancer as a metabolic disease. He identified 11 hallmarks of cancer, and I'm not going to go into it because I spoke a lot about it last time, but it's a great article and everybody in here should read it. So this just speaks to that model, and I'm skipping it. So before I go any further, if you don't remember anything else, if you saw the lecture, it's going to be very familiar. Nothing you eat is neutral. Everything you eat is going to have an impact for better or for worse. It's going to either drive better states of health or worse states of health, heal or harm. And when we're talking about cancer, it's either going to further the dysfunction that enabled the cancer to ensue and pursue, or it's going to restore function and enable the body to do what it was designed to do. You can't do that without real food. A person who eats real food is going to have greater vitality, and greater vitality is going to equal greater outcomes. A vital patient is going to be the one who doesn't just survive treatment, but one who thrives through it. Because one of the things we can all agree on, whether or not you like the natural approach or not, excuse me, is that we want our patients to have good quality of life. We don't want them to just get through treatment and feel lousy. We want them to get through treatment and gain some years and want to live those years. So to have a life worth living. Nutrition is one set of tools in a toolbox. Our patients need a very well-outfitted toolbox. So we have in a toolbox, we have Phillips heads, we have flat heads of different sizes, and that's kind of like nutrition, but there are also needle nose pliers of different sizes, different kinds of wrenches, different types of washers and screws, and if you don't have all of those tools, you're not going to go very far. And I would say if you have a toolbox without your screwdrivers, it's not going to be a good toolbox. So in my opinion, I'm a little biased, but every cancer patient needs to have a nutritional component in their care. And again, I'm just one set of tools. I can do things you cannot, you can do things I cannot. Together we can do great things. I rarely work in isolation. In one of my slides, it said I refer to others often. And I work hand in hand with many clinicians on most of my patients. If you want to go fast, go alone. But if you want to go far, go together. Again, we don't just want patients surviving their treatment. We want them surviving for the long haul and having a life worth living. So, the problems. If you ask patients what is most problematic, most of them will tell you fatigue. I've seen different figures in terms of its prevalence, but what I have seen across the board is more than half of those that say they have fatigue say it's moderately severe to severe. And it also is a known influence in patient outcomes. The greater the fatigue, the worse the outcome. It's the most distressing to patients. If you ask clinicians what's most problematic, most of them will tell you cachexia. And that's for a reason. I've seen, again, different figures as far as how prevalent it is. But one thing I've seen repeated is that it accounts alone for 20% of cancer deaths. And within 1 year, when a patient has cachexia, there's an 80% mortality rate. That's pretty significant, and it's really scary. So we need to take it a little bit more seriously, in my opinion, and that's one of the reasons I'm going to talk about it. So what drives it? Can you pass me my water? It's a systemic inflammatory response to the tumor, and we see an increase in the cytokines you see on the screen. So those cytokines disrupt many different processes in the body. But there are many different things that are feeding back and forth between each other in this condition. Some people, when they're measuring the development, the progression, et cetera, of cancer cachexia, look for the acute phase reactants that are increasing and decreasing. CRP and fibrinogen increase, albumin decreases. But in cachectic state, we see resting energy expenditure increase. The tumor vies with our bodies for fuel and biosynthetic substrates. So that leads in part to the increased resting metabolic rate. And in an earlier stage, it's 200 calories maybe. But in a later stage, it can go beyond 400. But in a later stage cachectic patient, what do you see? They're getting more tired, they're getting more anorexic, less appetite. So their need is growing and their ability to meet basic needs is declining. So that gap is really wide. So we need to have better measures to catch it a little sooner and to monitor it a little bit more closely. And if you measure the inflammatory cytokines, you can do that. Those inflammatory cytokines are known to drive insulin resistance. They influence insulin signaling. They can also influence skeletal muscle, which I'll talk about in a second. We know, according to Warburg and the Hanahan article, there's an increased glucose uptake, and that drives insulin resistance. A greater IGF-1 drives malignant pathways and tumor proliferation. It's the opposite of what we want. So I talked about dietetics a second ago. Dietitians care about calories. So they push calories when a patient is cachectic. Unfortunately, we've seen that has never improved survival rates, and it's never improved quality of life in cachectic patients. We need to look beyond calories. One of those Ensure or Boost Pluses that you saw on that screen has almost a day's worth of carbohydrates for a lot of cancer patients who don't tolerate carbs. It's going to do more harm than good. So we see impaired protein synthesis and increased catabolism. Increased catabolism, decreased anabolism. But we also see a mitochondrial component to that. So most of you know when you had a cachectic patient because they're wasted. You can see it. What's interesting is that cachexia, most people look at it like it's starvation, but it's very different metabolically speaking. It looks a little bit more like obesity in some ways, but it also looks a little bit more like an infection, excuse me, than either obesity or starvation. And it has to do with the differences in the way the adipose is wasted. And in a starved state, we'll see more adipose wasting in general, but in a cachectic state, the wasting really starts and is the worst in muscle wasting and lean mass wasting. The mitochondrial dysfunction is really interesting to me. So what we see in states of cancer, not even just cachexia, is that there's a decreased mitochondrial biogenesis and an increased mitophagy. So we're building less and breaking them down faster. And then there's loss of function too in various aspects. And that is going to affect ATP synthesis. Remember basic anatomy physiology. Where do you make energy? In the mitochondria. So if you're not able to make energy, there's going to be an effect on skeletal muscle and organic function. And then we see profound derangements in the microbiome and intestinal malabsorption, increased intestinal permeability in most chronically ill patients, in nearly all cancer patients, but definitely in, I would say all, but maybe I'm a little biased, cachectic patients. And the microbiome is going to be an independent influencer of all of these mechanisms I'm speaking about. What we know is that when there's an imbalance in the gut microbiome and we have a heavier load of those opportunistic pathogenic microorganisms, we're going to see an increased output in those inflammatory cytokines. Now, what's interesting in the state of cancer is when we're just putting out inflammatory cytokines in response to an insult, like a microbiome insult, or some other, maybe an environmental exposure, that will certainly do it. We see more of a secular fashion, whereas the tumor can secrete its own inflammatory cytokines. So it's like a double load already, but the tumor is not doing so on a circadian rhythm. It's doing so continuously. So we don't just see higher levels, but we see higher levels sustained. And it's really problematic. The microbiome can drive systemic circulation levels higher of those. So then that's like a quadruple whammy. What we also know is that there's this feedback system that happens. Cancer drives inflammation. A disturbed microbiome drives inflammation. Inflammation drives a disturbed microbiome. Disturbed microbiome is going to drive GI inflammation, which is going to drive systemic inflammation, which is going to affect muscle function and synthesis. But if you have less muscle and less ATP in the muscle, well, that's going to cause inflammation, which can affect the gut, the cancer, and the microbiome. So all of these things are like feeding each other forward when we're in a metabolic deranged state like cachexia. So what do? Well, there's an increased calorie need and there's an increased protein need. We need to make sure we meet those needs, but doing so is not going to give us any long-term solutions alone. We need to focus also on the cofactors that drive all of the enzyme reactions in the body. Those are vitamins and minerals. And now we're finding too that the phytonutrients in food can serve as cofactors in many cases too. So the compounds in foods that give them their color, their aroma, their taste, those are the phytonutrients. And we're finding now, like I said, they are just as essential. So a flavonoid-rich diet is going to be a diet that is full of those colors, those aromas. And that has been shown alone to be beneficial in cachectic patients. High-fat diets and anti-inflammatory diets are really important. So we want to support the mitochondria, and one of the best ways to do that is a high-fat diet. The most popular of the high-fat diets is a ketogenic diet. But just your average keto diet is not great for cancer because sometimes there's not really enough emphasis on the amount of protein people are getting, and we don't see enough of those flavonoids coming in. So an anti-cancer keto diet is going to be one that covers the protein base and also pushes all of those phytonutrients in ways that don't drive up the carb intake. For those of you who don't know, it's like 75% of calories coming from fat. And we've seen benefits in animal studies from just low carbohydrate diets that are fat enriched, but it's not any kind of fat enrichment. We think a lot of times with keto diets, those medium chain triglycerides, CLA8 or CL8, etc. But what we see being beneficial are those omega-3 EPAs. So there are different types of omega-3s in fish. EPA is one of them. And it's not DHA, it's just EPA. But EPA alone, when added to cancer animal patients, has been shown to decrease tumor proliferation, decrease muscle wasting, increase protein synthesis, restore wasted fat mass, reduce inflammatory cytokine output, enhance pro-inflammatory cytokine and pro-inflammatory prostaglandin synthesis. So what we want to do with the diet is really antagonize those inflammatory pathways and calm the the inflammatory pathways when we can. Excuse me. Exercise is really important, and a lot of people think that's a lofty goal for fatigued or cachectic patients. Do I have any physical therapists in the room? Oh, such a shame. Because the physical therapist would tell you there is so much research supporting the role of exercise, therapeutic exercise, in fatigue and in cachexia, both. And the difference is it needs to be done. So when people think it's a lofty goal, it's because people have this expectation of what exercise should be, but it needs to vary based on daily tolerance. And that could be 5 minutes a day and an hour tomorrow, 10 minutes the next day. So it needs to be something that's under the discretion of a person who's experienced in working with cancer patients. That can really help guide the cancer patients who are already overwhelmed, whose brains don't work well because they're inflamed, etc. And then somebody asked me, didn't you mean to put melatonin and carnitine on your fatigue slides? No, because there's a lot of research in cachexia as well as fatigue. And I'm not going to go into that because that's where the individualization comes in. But I will say, with melatonin, not all melatonin is created equal. I would never recommend any of my patients go buy anything that is available on the consumer front. I use 2 melatonins in my practice, and I've been in practice for a few decades and used many different melatonins. And the number to treat with a lot of them is not so great. Carnitine, I think I practiced too many times yesterday and I wore out my voice. There are a few different forms of carnitine. We need to know what kind of patient needs. Do they need acetylcarnitine, carnitine tartrate? Again, that's going to vary per person, and that's where the beauty of this personalized approach comes in. So this speaks to that feed-forward loop where everything's feeding into each other. And if you ask for those slides, you'll see the reference, so you can go read the article. So fatigue, we see a lot of those same mechanisms, those inflammatory cytokines. In cancer-related fatigue, we see peripheral and we see central fatigue. And those inflammatory cytokines drive both because they affect muscles, so that's going to affect peripheral fatigue, but they also act directly on the brain and on the gut-brain axis, the HPA axis, and then we see some independent HPA axis dysfunction as well. And then circadian rhythms are really thrown off in a lot of fatigued patients, also a lot of cachectic patients. How many of you here have had patients come in and tell you they can't sleep at night and they can't stay awake during the day? Yeah, it's common. If you ask patients, probably more of you would raise your hands. With fatigue, it's thought that it's underreported because there's no objective way to measure it. And unfortunately, we're not being educated well on the right questions to ask to really be able to gauge it in our patients. So we really need to make it a point to ask about these things and to intervene as much as we can. So for circadian rhythm dysfunction, and you'll see this on the next slide, but I'm talking about it now, one of the most effective things is strategic sunlight exposure. Whether I have a cancer patient or another non-cancer patient, when there's circadian dysfunction, what I have them do is go outside every day for 2 weeks at high noon, face the sun with the eyes closed. And if I can, I have them lay eyes on the sunrise and the sunset. And that can do it in less than 2 weeks alone. But it's really important to also have sleep schedules and eating schedules like I'll talk about. And one of the reasons that's important is because it stabilizes the microbiome too. The microbiome, those microbes act directly on the gut-brain axis. They produce neurotransmitters, which influences perceived levels of fatigue, and they influence neuronal activity. And because they're influencing insulin signaling, that can affect energy. There's a profound impact on the mitochondria. So we see lots of hits the mitochondria are taking. Have any of you in here heard of the cancer steal? It's like I said, it's sci-fi turned into reality. There are certain cancer cells that create these microtubules that attach to certain kinds of cells in our bodies and essentially suck the mitochondria out. So it's another loss. There's a lot of mitochondrial components in various aspects of cancer. And we know that a lot of treatment really does some damage to the mitochondria that can be repaired when it's supported. So one of the other things I have not talked about is dehydration. Dehydration affects CNS activity. It also affects ATP and mitochondrial function. So we're going to see dehydration driving central and peripheral fatigue. Low water means low energy. So what do? We want to make sure patients are hydrating. We want to get them moving. Movement is going to help so much. Microbiome support, I'll talk about that in a second. And an anti-inflammatory blood stabilizing diet. And then the consistent schedules. And remember, I said we're not just treating the physical body, we're treating the non-physical body. There's an HPA axis component. So we want to make sure we bring in some of these other modalities. Remember, many tools need to be in our toolbox. So we want to end eating at least 3 hours before bedtime. And we want exercise to not go too late either. And sometimes that's challenging in people whose circadian rhythms are really off. Sometimes you have to grin and bear it initially. So what I like to have my patients do is create this routine where they have this wind down time, no overhead lights, no screens, no stressful conversations, no stressful activity, TV shows, etc. Nothing too stimulating. Don't try to learn a new language. And then relaxation techniques. So you should see some overlap, right? One of my teachers a long time ago said, we want to use this spider web approach. Has anybody heard of that? Yeah. So what we're looking to do is find that one string that unravels the whole spider web. So if you look here, mitochondria, inflammation, and microbiome, if you have those as your targets, you can hit a lot of those mechanisms I just discussed. So how do you do it? An anti-inflammatory diet, microbiome support, targeted targeted exercise, and mind-body practices. The latter is a whole day's worth of lectures. I'm not going to talk about that. I'm not an exercise expert, but I can talk a hell of a lot on the diet, the microbiome. So this is a review for anyone who saw the last lecture. Ask for the slides. Fostering an appropriate microbiome. So what you need to know is you need real food. Factory food is not going to do it. Real, whole, fresh, vital, colorful food. You just saw pesticides listed numerous times in environmental factors that influence cancer. You will never have a healthy microbiome if you have a lot of pesticides, herbicides, and fungicides. They kill healthy microbes, so it needs to be clean. The hallmark of a healthy microbiome is diversity and robustness, the hallmarks, I should say. And you cannot have a diverse microbiome without a diverse diet. So here are foods that have certain kinds of soluble fibers that are known to feed a healthy microbiome. The anti-inflammatory diet. It's very, very colorful. Half of an anti-inflammatory diet should be produce. In a cancer patient, it should be more like 2/3 to 3/4. Lots of herbs and spices. You can eat a couple of cups of vegetables or, a tablespoon of herbs and spices and get the same anti-inflammatory benefit in some cases. Colorful and aromatic, I will not be able to say that enough. Whole, real, fresh food. And then rich in anti-inflammatory oils. Here are some of your heavy hitters: cruciferous veggies, dark green leafy veggies, the Asian mushrooms, sea vegetables, green tea, those culinary herbs and spices. Our therapeutic fats. Not all fish is going to be high in omega-3s, and some fish that is high in omega-3s is pretty toxic. You saw heavy metals listed in the talk right before me. Some fish is going to provide those heavy metals if you eat that for your omega-3s, which is not what we want when we're trying to oppose cancer processes. There are a lot of monounsaturated fats that have anti-inflammatory properties as well. Obviously, we want to avoid the more noxious foods, factory foods. If it goes to a factory and it changes shape, it's not so great. What I want you to do is to be able to walk out in my magic field and point to the tree, point to the bush, point to the stream, the ocean, whatever, and show me your food. If you can't do that, it's not real. Real food is going to make a vital patient or a vital person, not factory food. more not so great foods. Anybody who's eating a packaged food, even if you think it's really healthy, read the labels. Sunflower oil is in everything. It drives inflammatory pathways. Remember, we're trying to oppose those. More flavored, sweetened stuff. Nutrition's never neutral, y'all. Everything you eat is going to have an impact. It's either going to drive the dysfunction that drives some of these cancer processes and the problems occurring in cancer, like cachexia, like fatigue, like insomnia, like depression, anxiety, pain, you name it. Or it's going to restore function and enable the body to do what it was designed to do. Eating real, fresh, vital foods leads to vitality. It's not hard. I gave you some general guidelines. If you don't know how to put it in practice, there are many more tips when you ask for those slides. Color, rainbows, real food, lots of produce, healthy fats, things that smell good, things that are pretty. I'm just one set of tools. I do best as part of a whole toolbox. Mine's pretty and pink. I don't know what yours looks like. Alone we can do so little, but together we can do so much. I want to work with other people. My objective in doing anything professionally is to improve the lives of as many people as I can with my expertise, using my expertise to improve a person's state of health, because that improves their ability to engage in life and their quality of life. Remember, we want patients to thrive. I can't talk.